Welcome to our video on complications in the newborn period, where we'll be focusing on neonatal jaundice. Let's get started. Here's our overview slide. We'll cover causes of neonatal jaundice due to both unconjugated and conjugated hyperbilirubinemia. Let's start with unconjugated. While neonatal jaundice is typically a benign condition, it can have devastating consequences if severe. If bilirubin levels become too high, an infant can develop kernicterus. Kernicterus is bilirubin encephalopathy secondary to deposits of unconjugated bilirubin in the basal ganglia and brainstem. This leads to irreversible chronic neurologic deficits such as cerebral paresis, hearing impairment, movement disorders, and intellectual and developmental disabilities. Here is an MRI of a patient who has kernicterus. Take a look at the white arrows. They're pointing to hyperintense lesions in the basal ganglia bilaterally, which are areas where bilirubin has deposited and caused kernicterus. When an infant presents with jaundice, there are several components of the history that are important to obtain. First is the gestational age of the infant. Next, one should determine if the infant experienced any birth injuries, such as caput succedaneum or cephalohematoma. This is important to know because the breakdown and reabsorption of red blood cells from these injuries can lead to jaundice. In an infant with jaundice, it's also important to learn the maternal blood type and if the mother experienced any infectious diseases throughout pregnancy. Information about any family history of jaundice is important to obtain because there are inherited disorders that can lead to hyperbilirubinemia. There are several aspects of the physical exam that are also important to evaluate in a neonate with jaundice. First, jaundice typically spreads in a cephalocaudal pattern. Therefore, infants with jaundice of just the head will have lower bilirubin levels than in an infant with jaundice to the abdomen or legs. It's also important to assess for cephalohematoma, bruising, and hepatomegaly in order to help distinguish potential etiologies for the jaundice. Stool color should be evaluated because pale or acholic stools can indicate an obstructive cause of jaundice. The infant should also be assessed for signs of dehydration or sepsis that could be contributory. In addition, one should compare the weight of the infant to their birth weight to see if they have lost an excessive amount of weight. Here is an image of an infant with jaundice affecting their entire body. Remember that jaundice spreads in a cephalocaudal pattern, so the discoloration of the infant's skin would have started on their head and progressed down their body. The yellow discoloration of the skin is most obvious here on the forehead. Physiologic jaundice is a benign hyperbilirubinemia that occurs in many newborns. The onset of this jaundice is typically after day 1, with the appearance of jaundice peaking at days 3 to 4. It will typically resolve by days 7 to 10. There are several factors that contribute to the development of physiologic jaundice. First, neonatal red blood cells have a short lifespan, leading to increased turnover and the production of increased amounts of bilirubin. Second, the clearance of bilirubin is decreased in newborns due to immaturity of liver enzymes. Finally, there is an increase in the enterohepatic circulation of newborns as unconjugated bilirubin increases, eventually leading to jaundice. Physiologic jaundice is a clinical diagnosis. However, it's important to pay attention to bilirubin levels. In most neonates with physiologic jaundice, total bilirubin levels should not exceed 18 milligrams per deciliter. Next, there are two pathologies related to breastfeeding that lead to jaundice. First is breastfeeding jaundice. This is jaundice that develops within the first week of life, secondary to decreased milk intake or poor feeding. This results in dehydration and hypovolemia, which leads to an increase in the enterohepatic circulation and hyperbilirubinemia. In order to evaluate for breastfeeding jaundice, it's important to evaluate an infant's hydration status. This can be done by assessing stool and urine output. Infants around 1 week of age should be producing approximately 3 to 4 stools and 6 wet diapers per day. Any less than this should prompt further evaluation to assess for dehydration. In addition, one should compare the weight of the infant to its birth weight. If the infant has lost more than 10% of its birth weight, it's not getting enough nutrition and may require formula supplementation in order to prevent breastfeeding jaundice and further malnutrition. Breast milk jaundice is another cause of jaundice related to breastfeeding. However, this jaundice has a later onset that's typically in the 2nd to 3rd weeks of life. There's no clear etiology for breast milk jaundice, but it's thought to be related to high levels of beta-glucuronidase in maternal breast milk. If an infant develops breast milk jaundice, they can continue breastfeeding. However, it's important to monitor their bilirubin levels to ensure that the bilirubin remains unconjugated and the levels do not increase. If either of these changes occur, they should be evaluated for another underlying cause of the jaundice. Hemolytic disease of the newborn can also lead to unconjugated hyperbilirubinemia. This jaundice will typically present within the first 24 hours of life. It can be secondary to either ABO blood group or Rh incompatibility, but ABO incompatibility is usually less severe. Hemolytic disease can range from either a mild disease with jaundice to a severe anemia. In order to evaluate for potential hemolytic disease, the blood type of the mother and the infant should be obtained in order to assess for potential incompatibility. Gilbert syndrome is an inherited condition that can lead to neonatal jaundice. This is a benign condition that's inherited in an autosomal recessive pattern. Patients with this syndrome will have a deficiency of the enzyme UDP glucouronyl transferase, which is also known as UGT. This deficiency results in a mild, fluctuating non-hemolytic jaundice. This condition may be evident at birth, but more commonly manifests in adolescence and continues into adulthood. The jaundice seen in Gilbert syndrome can be exacerbated by certain drugs, fasting, or stress. The last etiology of unconjugated neonatal jaundice that we'll discuss in this video is Crigler-Najjar syndrome. This syndrome is secondary to a complete or near complete absence of UGT. Type 1 is associated with a complete absence of this enzyme, while type 2 is associated with a near complete absence of the enzyme. Type 1 is fatal because an absence of the UGT enzyme results in the complete inability to eliminate bilirubin, which will inevitably lead to kernicterus. In severe cases of Crigler-Najjar syndrome, infants may have bilirubin levels that exceed 50 milligrams per deciliter. Okay, now let's discuss the management. When an infant has been diagnosed with unconjugated hyperbilirubinemia, their management will follow recommendations based on the Butani nomogram. This tool helps determine the risk level of an infant, which guides treatment. If an infant needs treatment, initial management will be with phototherapy. Phototherapy converts the unconjugated bilirubin present in the skin of the infant to a water-soluble form that can be excreted. The goal for phototherapy is to achieve bilirubin levels less than 15 milligrams per deciliter. However, infants with more severe jaundice from unconjugated hyperbilirubinemia will require an exchange transfusion. The threshold for exchange transfusion in a 24-hour-old baby who is born at term is a total bilirubin level greater than 20 milligrams per deciliter. However, the threshold for transfusion will vary based on risk factors, clinical presentation, and the age of the infant. Exchange transfusions may also be required in an infant with bilirubin encephalopathy, inadequate response to phototherapy, or with a rapid rise in the bilirubin level. An exchange transfusion will be performed by exchanging matched blood through an umbilical catheter. Here's an image from our partnership with Amboss, which highlights several important features of a Butani nomogram. The Butani nomogram is a helpful tool to guide the management of an infant with jaundice. In order to determine an infant's risk category, their serum bilirubin can be plotted with their postnatal age on this chart. Serum bilirubin levels are represented on the y-axis, while postnatal age up to 144 hours is represented on the x-axis. After plotting these 2 points on the nomogram, the risk zone of the patient can be determined and they can be managed accordingly. Okay, now let's move on to discuss conjugated hyperbilirubinemia. This is typically secondary to failure of bile excretion, which can be due to a variety of causes, including physical obstruction, torch infections, cystic fibrosis, and metabolic diseases. When evaluating an infant with jaundice, it's important to remember that a conjugated hyperbilirubinemia is never physiologic. One etiology of conjugated hyperbilirubinemia is biliary atresia. This is the most common surgical cause of neonatal cholestasis and is due to obliteration or fibrosis of the biliary system. This typically presents later than other causes of jaundice, typically around 3 to 6 weeks of life. It's also associated with acholic or pale stools and dark urine. Biliary atresia is diagnosed with an ultrasound showing an atretic small and irregular gallbladder. Another cause of conjugated hyperbilirubinemia is choledochal cysts. These cysts can be due to maldevelopment of the biliary system while in utero. These may present in infancy as an obstructive jaundice with an abdominal mass. The classic triad of choledochal cysts includes abdominal pain, jaundice, and an abdominal mass. Choledochal cysts, like biliary atresia, are also diagnosed with ultrasound. They may even be first noticed on prenatal ultrasound. If a patient is diagnosed with unconjugated neonatal hyperbilirubinemia due to an obstructive lesion, the lesion should be removed in order to treat the patient. In biliary atresia, patients may undergo a surgery known as a hepatoportoenterostomy, or a Kasai procedure. This procedure connects the liver directly to the small intestine, which allows bile to drain. And this procedure can precede a liver transplant. However, if the patient has liver cirrhosis secondary to an obstructive jaundice, they will require a liver transplant. All right, let's wrap up with a question. A 5-day-old boy is brought to the physician by his mother who reports yellow discoloration of her son's skin. The patient was born at 39 weeks of gestation via vaginal delivery. His birth weight was 3,000 grams and his current weight is 2,500 grams. The mother is blood type A positive while her son is blood type B positive. In addition to jaundice, the mother notes that the patient is less active. He had 3 wet diapers during the last day. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 55 over 40 millimeters of mercury, a heart rate of 175 beats per minute, and a respiratory rate of 50 breaths per minute. He is breastfed every 5 to 6 hours. His total bilirubin levels are 10 milligrams per deciliter with a direct fraction of 0.2 milligrams per deciliter. Which of the following is the best next step in the management of this patient? A. Encourage more frequent breastfeeds. B. Initiate phototherapy. C. Initiate exchange transfusion. Or D. Reassurance. All right, this patient is presenting with jaundice. Additionally, he lost more than 10% of his birth weight. He had 3 wet diapers during the last day. Normally, the number of wet diapers within the first week of life should be equal to the number of days since birth. For example, a 5-day-old neonate should have at least 5 wet diapers. This patient has hypotension and tachycardia as well. All of these findings are consistent with severe dehydration. Dehydration is also supported by the fact that he is breastfed every 5 to 6 hours. Normally, a neonate should be breastfed every 2 to 3 hours. Considering everything that we've discussed so far, the most likely diagnosis of this patient is breastfeeding jaundice, and this is caused by insufficient breastfeeding. Decreased frequency of bowel movements causes retention of more indirect bilirubin, resulting in jaundice. Therefore, the best next step in the management of this patient is to encourage the mother to breastfeed more frequently. So the correct answer is option A. Here's a table which helps remind us of the different etiologies of neonatal jaundice, which we've discussed in this lecture. Pause the video and take some time to review this if necessary. Take a look at the differences between breastfeeding and breast milk jaundice here to refresh your memory as it pertains to this question. Breastfeeding jaundice is due to decreased milk intake causing dehydration. Therefore, breastfeeding jaundice will be associated with signs of dehydration, such as decreased urine or stool output. Additionally, breastfeeding jaundice will usually present in the first week of life. In contrast, breast milk jaundice is due to products in the milk and does not have any signs of dehydration. It also presents later, around 2 to 3 weeks of life. All right, let's discuss why the other options are incorrect. Options B and C are incorrect because phototherapy and exchange transfusion are necessary in severe indirect hyperbilirubinemia. This patient, on the other hand, has a mild hyperbilirubinemia marked by total bilirubin levels of less than 10. Option D is incorrect because reassurance would be appropriate for physiological jaundice. This patient has explicit signs of dehydration, making physiologic jaundice less likely. So again, the correct answer is option A, encourage more frequent breastfeeds. And that concludes this section.